morning. I like to come out and talk so we can have a conversation rather than me stand behind a podium. So it looks like we're talking together, because this is really a conversation. And I just said to my colleague here, thank you for making me follow your comments, being a member of the federal government. But I'm so honored to be here. Thank you so much for this opportunity. And I'm so grateful to work in a fabulous office dedicated to addressing health equity when it comes to HIV, and to have my colleague here, Mr. Lamont Scales, with me. He is in charge of all of our activities around gay and bisexual men. So thank you so much, Lamont, as always, for supporting and being here. So if you have any questions related to that, as Lamont's supervisor, I'm just going to point right to him, right there. That's the good thing about having him here. All right, so we're going to talk a little bit about social determinants of health, which is very important. And I love to start everything with a quote. Health inequities and the social determinants of health are not a footnote. They are the main issue. I think that's very important. This comes from Sir Michael Marmot, who is the guru when we talk about social determinants of health. So let's begin with that as the backdrop of what we're talking about. So I'm going to talk a little bit, just give you some key definitions of what we're talking about with social determinants. And then, because I do HIV work, and I'm not here to do a HIV talk, but that's what I do. So I'm going to talk about how those social determinants apply to HIV, and a closing statement as well. And because I love my job, I really do, and I'm real close to being able to retire, I like to keep that disclaimer right down there at the bottom. The findings and conclusions in this report are those of the authors and don't necessarily represent the official position of the Centers for Disease Control and Prevention. Okay? All good? All right, so let's get started. Can you hear? Okay. Key definitions. What is equity? So we can start with the same everybody understanding. The absence of avoidable, unfair, or remedial differences among groups of people, however those people are defined, whether it's socially, economically, demographically, geographically, or by any other means. And you see this nice tree over here. Let's say that represents a community. You see the strengths, the roots of that tree. The tree is healthy because of all of those things that we see there. You see everything: access to parks, natural resources, affordable, healthy local food, community and public safety, strong, vibrant neighborhoods, family wages, jobs and job trainings, access to health and human services. All of those things are social determinants, really, but they actually improve equity within communities. So that's very important. So when we talk about equity in health, that means that everyone should have a fair opportunity to attain their full health potential. That's equity in health. No one is disadvantaged from achieving this potential. That would be equity in health and how it's defined. Okay, a health inequity then is a difference in the health status or in the distribution of health determinants between different population groups. That's inequity. There's some type of difference. And if you look at that word cloud over there, you can see all of the things related to inequity. And one thing, I try to update my presentations at least every year because there's always new information coming out. And one of the things that's new in this word side, is one-sideism. Have you heard of one-sideism? One-sideism. That's an ism. It's new. I had not seen that before. And really, one-sideism has to do with a person being tunnelly focused only on their side of an issue. Now, I'm not saying you have to agree with the other person's side, but if you're going to work with someone, you've got to at least be willing to understand and consider that there's more sides to an issue than your side. If you can't do that, there's something called one-sideism. I've been doing reading on that to see how does that affect the work we do. Of course it's going to affect the work we do. And again, you don't have to agree, but you do need to understand. When you come to talk to people, you want to do work with them, you want to address determinants, you have to meet people where they are. You've got to be able to understand, right? So that's a new one I had never heard of. The rest of them I heard of, but one-sideism. So, and there's a body of work now coming out around how that affects individuals' health. Very interesting. All right, so a health disparity then, and this is the actual measure. So anything that's seen to a greater or lesser extent between two populations, that's the disparity. And that can be race or ethnicity, sex, sexual identity, age, disability, your SES, or where you live. All of those things in terms affect health disparities, okay? And then so now to what I'm really here to focus on. Now those are the basic definitions. So we understand health, we understand health equity, we understand equity in health, we understand inequity, social determinants of health, and this is the World Health Organization's definition. The conditions in which you are born, grow, work, live, and age, and all of the systems around you that shape the condition of your life. Those are social determinants. So it could be economic policies, development agendas, social norms, social policies, political systems, all of those things. That's the World Health definition of social determinants. Now, healthy people also has a definition. What do you see as the difference there? There's one word that's the difference: worship here. Worship. So the World Health Organization understands that the conditions in which you are born, live, learn, work, play, worship, and age also affect a wide range of health functioning and quality of life outcomes and risks. I think it's great that this definition includes the faith community, because it should. Those are the differences just between those two. All right, so now, just for a minute, I want to go through each one of those little sort of circles that talk about social determinants and give you examples of what we mean by that, okay? So when you talk about economic stability, you're talking about whether not only are people employed, but are they underemployed? That's also an issue. Not just being employed. Employment is important because it's associated with so many things: access to care, the schools that you have, the housing that you have, all of that. But underemployment is also an issue. There are people who are employed, but they're underemployed, so they still can't take care of their health or their daily living activities. Food insecurity, and I'm often asked all the time, why do you talk about food insecurity and you work in HIV? And I always say, because you'd be surprised what we do in order to get food. We all have to eat. We have to eat. And if I'm going to talk to someone about prevention and they haven't eaten for the last week or so, or they don't know where their next meal is coming from, are they listening to me and what I have to say? No. No. And you have to understand that. You do. You really do. One of the greatest things I did, I think, when I went back to do my graduate work, and I was older, I was a practicing pharmacist when the first cases of HIV were identified in the early 80s. And so I did a PhD later in life, but I worked with women living with HIV at the Ponce Center as trained at Hopkins, but I worked there for a postdoc. And the best thing I understood from, you get all this knowledge, but you've got to be able to apply it. You've got to be able to apply the knowledge. And you have to understand that people are not data points. People are people. And we need to be able to take the work that we do and integrate it into their lives. They don't need to, it's not opposite. We need to help them. They're not, that's how that works. But I remember having, people saying to me, I understand what you're trying to tell me, but I have children and they're hungry. So I'm going to do whatever I need to do to make sure that they have food. That's something you need to take into consideration when you do the work that you do. So food insecurity is a big issue. And it's not just getting food, it's access to quality food. Fruits, vegetables, how far do you have to walk in your neighborhood to get fruits and vegetables? Are there food deserts in your neighborhood? Those are social determinants. Housing instability, you'd also be surprised how people behave in order to get stable housing. A place to stay is necessary. And the data around poverty. Of course, that's a social determinant. Okay, so then when we look at education, early childhood education and development, and I've read several papers that talk about, in some racial ethnic minority communities, by the time our children get to 3rd grade, they're already behind. And education is the most modifiable social determinant of health. It is the most modifiable social determinant of health. If we can work on that, because it's so connected to everything else. So connected to everything else. And enrollment in higher education, high school graduation, language and literacy, and it amazes me sometimes when I think about, and I grew up in the 60s, early 70s, and I think about sort of integration, all the things that happened around that. There were people who were sort of pushed through school and by the time they got to their higher grades, they couldn't read, and no one even bothered to try to help or assist or anything. So you essentially graduated someone who can't read, so they cannot take care of their daily living at all as well, and they're affected. Everything they do is affected by that. So it's very important in terms of language and literacy. I think this is a big one. Social and community context. And why? Civic participation. Do you participate? Where's your voice? So I'm at work, so but I am a private citizen when I'm not at work. Civic participation is very important. We know that discrimination is an issue. And that's discrimination in all forms, not just race, ethnicity, but however people look at you and define you and decide that they're going to discriminate against you. That could be gender, that could be gender identity, that could be anything. Incarceration, big one, because it removes people from communities to be in service. It removes them and disrupts. Social cohesiveness. How much does the community engage? How much do people engage? It is important for us to participate. It is important for us to participate in our communities and have our voices heard. That's important. Okay, health and healthcare, access to healthcare, access not only to healthcare, but what type of healthcare? Quality, good. Quality healthcare. And why is access to primary care important? That's prevention. You want to be able to get your physicals every year, get all your tests done every year. You don't want your only time to engage in healthcare to be when you're sick. That's important. And of course, understanding what you're being told. That's important as well. Now, neighborhoods. Crime and violence is a social determinant. If you live in a neighborhood that's affected by it, why is that important? Stress levels, fear. Are you going to go out exercising, taking care of your health? No, probably not. And then what does it do? It perpetuates a cycle. All of that in terms of, and the quality of your housing. All of these are social determinants. Okay, so it's really kind of this interplay of money, power, resources, those balls in the air. Those are what affect the social determinants of health. And if we're going to pursue health equity, then we're going to have to reduce disparities between groups of people who are more or less advantaged economically or socially. And when you talk about reducing disparities, you're not talking about, let's say, people start, one group is here and one group is here. If you just work on reducing rates, let's say of HIV in each population, everything goes down. Have you reduced the disparity? No. You've got to do more here. That's reducing a disparity. Okay? All right, so before I do this, any questions about anything I said? Definitions, understanding? No. Okay, and because I work in HIV and I am at work today, I do need to include information on HIV. Okay? So I'm going to talk just briefly about that. You may hear some of what you heard from my colleague here. It'll be slightly different because we work for different groups. But anyway, social determinants of HIV. So we know that HIV infection started to stabilize around 2013, right? These are HIV infections. These are new infections. But look at the disparity there. These are new HIV infections by race and transmission group, 2010 to 2016. Do you see, or 2010 versus 2016, the bar at the front, can you see that here? This group, who's African American, gay, and bisexual men. Relative stability that we saw, that's not what we want to see. Not with all of the efforts and the funding. We want to see that go down. And look here at Latino, gay, and bisexual men. and the differences. And then when we go to African American heterosexual women, we have seen a decrease, but who represented 60% of the cases among women in 2017? African American women. That's a significant disparity. It's a disparity. So when you just take a look at that, you can see, and these are new HIV infections, so that's incident, transmission. Now let's look a little bit at annual HIV infections among Latino and African American gay and bisexual men. This is 10 to 16. I'm going to leave that up there. Look at that age group. Look at what we're seeing. Increases. All right. So these are diagnoses. There's a difference. We calculate incidence rates from CD4 counts, right? It's estimated rate. These are actual diagnoses. These are diagnoses reported to us. 38,739 new HIV infections in 2017. 1 in 5 were in women. 67% were from male-to-male sexual contact. Disparity. Disparity. And this is a busy slide, but it does show you kind of everything that's going on. This is the total diagnosis in 2017. We did see a decrease in women, but the disparity among women, I can't leave here without telling you, the disparity is still there, significant disparity. Because I told you the bulk of the infections were in African American women. You see the rates have gone up in white persons who inject drugs, 25%. Relative stability in MSM, but up in 25 to 34-year-olds. When we look at what's going on with MSM, look at this. We already talked about those rates, and look at the bottom bar here in terms of diagnoses in 25 to 34-year-olds and the increases that we saw. And then if we look at diagnosis by race ethnicity, we still see that African Americans and Hispanic Latinos are disproportionately affected. There's much work to be done. So, and look at the South. These are people living with HIV. Why is that important? Because 8 out of 10 infections occur from people who are either aware of their status, or they're not aware of their status, or they're aware of status and they're not in care. So if you have more people living with HIV in an area, what does the transmission risk do? Increase. That's why we need to do work in the South. All right, now let's talk about some of the social determinants in HIV. Because the data tell us, and you all know this, the disparities are not about risk behavior. It's not that our groups are engaging in more risky behavior than others. That is the case with African American women. That is the case with African American gay and bisexual men. That is not what the data tell us. The data tell us that it's really related to some of these social determinants. And if we could address these social determinants, we could not only have a positive impact on HIV, but we could do it on chronic diseases and infections as well. Right? So education. And I already talked about why. Discrimination. Almost immediately, and I always say this, I have a very expressive face. And I think and I have to work on it. Even though I'm a senior citizen now, I'm still working on it. But imagine, I keep thinking, if a person comes in to be treated and your receptionist expresses her feelings or his feelings about that individual from a facial expression, then is that person coming back? No, no. Or if you decide as a healthcare provider, this person can't afford to pay for that, I'm not going to offer that. Or this person doesn't need to have this treatment, I'm not going to offer that. That's medical mistrust is an issue. Very much so. We already talked about access to health care and how that affects persons' social determinants. Of course, this is significant in terms of persons living with HIV infection and those at risk. Jobs, having funds to be able to take care of your daily needs. Homelessness, and we talked about why that's an issue. These are all social determinants that affect HIV. Transportation, And I'm often asked, why did you say transportation? If you can't get to care, how will you receive it if you can't get there? You have to be able to get there. It's an issue. And people will engage in behavior so they can get transportation. So we have to think about all of those things. And homophobia, talked about that. You know, it has to be, and stigma. Stigma is still a major issue. Stigma around getting tested, stigma around getting your results, stigma around living with the virus, stigma around being at risk for the virus. Now, I grew up in a very small town, very small. And I can remember, and I always say this, when individuals would go to the health department or to the doctor, by the time they got home, everybody knew everybody. Everybody was talking about having seen so-and-so down at the health department. And so if that's the case, especially in some of our rural areas, why would people go? It's still a problem. And there is no reason why some 30, how many years are we now post the first, what is this, like 36 years or so, that we are still dealing with stigma. Still dealing with stigma. I gave a talk on a group for HIV and aging populations, and of course they didn't think they were at risk. Several people said to me, I don't know why you're talking to us about that. That has nothing to do with us. That's young people, and that's people who are doing things they shouldn't be doing. I was like, okay, that's why I'm talking to you, because that was a wrong statement. You know, I mean, and in terms of why doesn't it have something to do with you? We should all be concerned about it. It's preventable, right? So let's talk about it and let's deal with some of the stigma associated with it. So really, if we're going to address health inequities, we got to go beyond just doing interventions. We have to really empower groups. There has to be some type of systematic change. Law reform, changes in economic or social relationships. All of that has to be done in order to do the work. So that's why it's so important in what you're doing today. We're going to have to do these things to make a difference, because we've got to address the social determinants. We have to. And if we are looking at the interventions that we're going to do, we got to do both. We can't just do biomedical interventions. We got to combine it with social and structural, because people have issues. I mean, I could have included childhood sexual abuse, all of those things, incarceration. All of those issues are related to the race that we're seeing. So we really have to do both. There has to be a combination. And we probably need to focus our efforts, given that 8 out of 10 new infections occur from people who don't know their status, or they know their status and not in care, then we need to focus on what are some of the social determinants that affect these. And we can do some of, make a difference. So I know you've heard about this, right? So I'm just going to end and leave this on your mind about the new plan that's in place, ending HIV in America. And these are the agency, Health and Human Services is the lead agency, and you see all of the other agencies that are involved. So all of the HHS agencies, OPTIVs, are involved in this plan. And achieving it is going to require resources. Right places, right people. So I leave that so you can see all of the agencies that are involved. You have also seen this, with the goals of reducing new infections by 75% in 5 years and 90% in 10 years. But you have not seen the map to show you exactly where the places are. And these are sort of data on the burdens in the US that shows where HIV transmissions occur more frequently and the areas where we're going to be focusing. You did hear the counties and the states. And this slide actually tells you what CDC's doing. So under the new plan, which, these are the strategies: diagnose, treat, protect, respond, and the workforce. And bringing testing to everyone who needs it, diagnosing infection, making sure that folk who are living with HIV have rapid comprehensive care, and they start treatment through working with HRSA, who does that, protecting those people at risk through interventions, including PrEP and syringe services programs, accelerating deployment of effective cluster detection, and having the right workforce, the boots on the ground. And so I'll head in with this last slide here because I think this is important. We do have an opportunity to end HIV in America. We have an opportunity. We know that we know what causes it. We know how to prevent it. We know that if individuals who are living with HIV know their status, they have the virus under control, they have virtually no risk of sexually transmitting to their partners. We know that. But now we have to address all of the issues that are affected with what we see. And for it to be successful, we'll need strong vision and a commitment from everybody to join us in the fight to end the HIV epidemic in America. And the last thing I would say is we cannot forget the social determinants of health. So thank you. Any questions? Yes, I hope it's an easy one. Come on, Lamont, if there's one.
I was wondering, and I know it's new, so maybe not quite yet, is there a specific plan in terms of how all the different agencies So just to repeat, and I know it might be still new, but is there a specific plan, tangible plan in terms of how the specific agencies who will be involved with, implementation, how that's going to work? Like, what will it take? Because I don't know if you recall, a few years ago, for example, there was a mandate, right, that prevention and care needed to work together. HRSA said it, CDC said it, you must have an integrated plan. And one of the things that, honestly, we've suffered with here in Georgia is not so much of a systematic, structural way of how do you get that done. And I'm not saying it's not happening, but how do you get all those people together? And what do you do?
Well, the plans are still in works. It's very new, but HIV.gov actually does have, I know there was like a one-page document that talked about what each one of the agencies would be doing. So I think that's sort of the first step. And then I do believe that, as time goes on, of course, then there will be more detailed plans. But I know they're still working on it right now. And there are key experts that are working on it at our agency. Daniel.
Hey, Dr. McCree. Thank you.
Wait a minute. I know I'm going to need Lamont for your question.
Thank you for the presentation.
Coming up to the stage.
Thank you for the presentation, as always. I guess my comment question is more towards your word bubble with one-sidedness or one-sidism. Thinking about, the fact that we see, 4 out of 5 infections are amongst gay, bisexual men, knowing that, we have half of persons living with HIV who are virally suppressed. How do we reconcile one-sidism, especially like in the terms of prevention and care, when we have so much data saying that we're just not addressing what we need to do, especially like from a cost-effective and a cost-benefit perspective. Does that make sense?
I think so, but I know that in terms of these efforts, we will have to work with the groups that are most affected, and you're relying on the data to tell you what those are. And we already know what the data tell us in terms of the populations that are most disproportionately affected. So in terms of what our agency is doing, we are focusing our efforts on that. There's more to be done, and I think that what we'll see happening that will help us is the more of the community engagement issues, because we've started to do that. There have been a couple of conversations around community engagement. I know that's going to continue and probably become more intense as we get into it. But I think that's how we're going to make that difference in turning the tide from what you're seeing. But I mean, the data already tell us where we need to focus. So it's already there. Did you want to add anything to that?
The only thing I will add is we work together. Thank you. Thank you, Daniel. I said the only thing that we can add as far as a data point, I said we can look at our testing data. I think states and cities should look at their local testing data to serve as a proxy for who they're actually serving. So we have our epi data that says this is who we should be serving, but when we look at our testing data, it looks totally different, right? So I think we need to look at that data, bring it to health departments, bring it to communities, and say, hey, how can we support you to make sure that we are reaching the populations that we need to reach?
Can I add like a comma to that?
Sure.
Thank you so very much. So looking at our testing data, I think last year it was 100, let's say 100,000 tests provided here in Georgia underneath your last funding announcement, 1802. And we see less than 10% of those testing, so 10% of 100,000 to 1,000 tests, specifically went to gay, bisexual, and or MSM, right? But 60% of new diagnoses for our state were in that 10%. What is the feedback from your division, your organization, on pulling, erasing those disparities?
So thank you so much for that. I would say that's problematic when you look at the disparity. When you look at, as Dr. McCree mentioned, if you want to reduce disparities, you're not bringing everyone down. You want to make sure that gap is narrowed. So I think you take that data, have the conversations with our local health departments, and say, how can I support you to make sure that we're reaching the populations that need this? Is that funding new organizations? Is that ensuring that those groups of individuals are at the table when planning is starting, when we're evaluating the information, ensuring that everyone who needs to be at the table is present. And we are working closely with our project officers to ensure those activities are occurring.
Yeah.
Thank you.
You're done? Oh, okay. Well, thank you then. Okay. Any other questions? Yes. Don't go. Good afternoon.
For the opportunity. My name is Dr. Spence Lewis. I specialize in infectious disease. One of the areas that may need expansion is behavior, modification of behavior, with respect to reducing the gaps, and the different variables that you would elect to get or to use to reduce those, the behavior, because certain behavior will cause you to get disease.
Correct.
And so I'm just wondering how you could put that to the public health department of this state, and how you would educate people as an instrument of prevention.
Well, we do have evidence-based interventions that work, and if you're talking about sexual risk behavior, you want to reduce sexual risk behavior or injection drug behavior or whatever behaviors that put individuals at risk, there are a suite of evidence-based interventions that are available on our website, Compendium of Evidence-Based Interventions. There are some that are supported by the agency as well, and that the health departments and community-based organizations are using. So there's a great body of work around behavior modification that's being done.
Yes, I can appreciate that, but to bring it to the community.
Okay.
Not everybody is web savvy.
Okay.
And so to bring these things to the community, to the
Okay.
general community.
Okay.
So it's not going to be done overnight. I'm aware of that. But
Right.
just, what options are there available for doing that?
Well, we have information that's free that you can give to distribute to communities that talk about behaviors, fact sheets. We have capacity building around individuals who like to do that kind of work. So it's all available and it's been done. And I'm happy to give you a card and sort of touch base with you and give you more information as well.
So one of the things, too, that came to my thoughts was abuse. Many people are abused who are in that department in that sexual activity. And what if one wants to give up homosexuality or that behavior? Are there options available for that? Not everybody wants.
I understand, but that's not something that the federal government would be involved in.
No, but it's a form of behavior. So I'm just saying what options are available.
that is not sort of what we would do, sort of the work that we would do. So, because we sort of meet individuals where they are, and we give individuals the information they need to protect themselves.
Yes.
But that's not the kind of
Well,
information.
I would just end on this comment. That's
Okay.
not good enough.
Okay, I'm sorry.
I say that's not good enough. You have to give people support. If
Around-
they want to give up homosexuality in any form, they need support. So that's, I just ended on that.
Okay.
We'll move on to our
So
next question.
next comment.
Good
next
morning.
question.
My name is Morris Singletary.
Okay, last question. Yeah, go ahead.
My name is Morris
No,
Singletary.
no. I'm saying you go ahead.
Oh,
Do we have? Okay. Mhm.
I'm a peer educator for the Ryan White program of Clayton County Board of Health. I'm interested in knowing, is there an approved curriculum that has been approved with public education? And because one of the social determinants was education, where I as a peer educator can go into a middle school, a high school, elementary school. Has it been approved? And have we made work on that? Because I've not seen it in Clayton County, and I would love to. I'm from a little small town called College Park.
Yeah.
And I would love to go into College Park or Riverdale and Jonesboro and see with an approved curriculum that I can say, hey, this is okay for me to say. And even if parents can come and join that, that would even be better. And as a church boy who will be in church on Sunday, do we have texts coming from the Old or New Testament that we can go into our religious places? Because that was one of the, and I'll be there. In fact, I'm there probably 52 Sundays. But I just wanted to know, do we have those things, and have we made inroads to the black church?
Well, first, let me answer your first question about our Division of Adolescent and School Health actually has curricula that are available. And if I could, one of us meet with you, I give you a card, we can connect you to Dash. The second question was around faith-based communities. Yes, we do have partnerships with faith-based communities through some of our campaigns and initiatives, so we can talk to you a little bit about that as well. Now, did I miss anything? What else was it? That's it? Okay, we're good. All right, no problem. What can we just take, please? Go ahead, all right.
Thank you. Hi, Dr. McCree, and hi, Lamont.
Yes.
Hi. Nice to meet you guys. Thank you so much for your presentation. It was so well done and put together. My name is Enrica, and I'm new to the Atlanta area and very interested in getting into public health and STD prevention. So I really enjoyed learning a lot about the social determinants that you mentioned, especially the stigma. And stigma comes from a place of shame, right, that people are carrying due to whatever situation or illness that they are walking through. So I just wanted to know, in your work, have either of you seen breakthroughs in when you were working with individuals in helping reduce stigma? And what are some tips that you can give us as people that are on the ground working with people to help us see those same breakthroughs?
Yeah, and we just had an article that was recently published that looked at some interventions that were focused on reducing stigma. I have a copy, I will give you that.
Okay.
The other is education is the key. You know, I think there's a section of our website that has information on how to talk to people about stigma around HIV. You can get fact sheets, you can talk about words that are appropriate and inappropriate and what those words actually mean. And then also, Let's Stop HIV Together, which is a campaign that we have that sort of shows that, you know, there's no face to HIV. You know, everyone is affected or infected in some way if you know someone or whatever. And how do we adjust, how do we use those type of images to sort of reduce stigma? And I think for me, and I'm thinking of how old I am, I know I shouldn't say that, but thinking about how stigma has been reduced over the life course for me, one of the most important things for me is knowing someone who has had to walk that walk. And what I understand is that I am not in a position to judge anyone. I am in a position to help. So the first thing I do is, can you tell me your story? Can I understand who you are and where you walk and where you stand and where you've been? Can I tell you my story? Now, can we work together in this arena so that we can make sure that everybody's protected and they understand what they need to live their best life? That's what it's about, really. So, you know, I think that kind of interaction with someone helps, and you play it forward. You know, once you understand and you're able to get it, then you're able to go out and you're able to do that with other people that you work with. But knowing someone, very powerful. Very powerful, and understanding that and recognizing your own biases and how they work as well. I think that helps as well. Did you want to say anything? But I have a great paper I'm going to give you guys.
Okay, so I can meet you afterwards and
Yeah,
take the
I know
paper?
we got to head to the office, but I'll get that paper to
Oh,
you.
thank you.
Dr. McCree and Lamont, before you all go to the office, let's give them another hand for being here. Thank you so much. As I indicated earlier, some 10 years or more, the CDC invited us here to Atlanta, invited us to get involved in this effort. And during that period, they pointed out that the National Black Leadership Commission on AIDS in BLACA, at that time I was representing the National Conference of Black Mayors, and they said that in BLACA was the organization that had been on the front line, and obviously today we're still on the front line. Mm-hmm. Now we need some money. I am serious. We would like to help you accomplish your goal. And we can do that because when President Obama was putting together the Affordable Care Act, he invited us to the White House. We sat across from here. He asked us to go back across the country to advocate, to get it done. And together, we got it done. Now, together, we want to partnership with you again. Right, Madam President? We want to do this together, all right? And we want to win by living together with the CDC. Let's do it.
I have a question,
Thank you.
Dr. McCree. It's really quick. I'm sorry. I know you guys are running. So my name is Vincent Roberts. I'm a community health worker at Positive Impact Health Centers. And I don't know if you can help me. So my dilemma is, like, I'm actually new to this field of work, right? So I've been living with HIV for 26 years. So I've been living it, right? And so my dilemma is, like I said, I'm new to this work, and so one of the things that I do at Positive Impact is help people who are struggling with HIV and taking their meds or whatever, help them to achieve viral suppression by eliminating whatever barriers that they're facing. But I too am looking to go out into the community, and one of the places is the faith-based community. I want to follow in the footsteps of Reverend Francis, right?
Yeah.
So my question is, how do you get black people, our people, how do you get black people to buy into what the CDC says, you know, and how do you get them to trust facts and, or to take medication? You know, we have all of this history as it's related to Tuskegee and Henrietta Lacks and people just black people not trusting white people or science in general, or, you know, to get them to not believe that this is a gay person's disease. Like, what do I need to do when I go out to these churches, you know, and I really want to go to I put tickle quotes around it, the straight black churches, because I feel like, for me, I feel like that's where some of the stigma starts, you know, because we take our cues and our values from the church. So anyway, that's my question and comment.
Well, I'm going to tell you some of the work that's being done. I think it was maybe last couple years ago, the AME Church, you know, initiated, and I don't know if it's a part of the doctrine, but every year their clergy have to be trained on HIV. And so we, three of us went to Houston and did a presentation around HIV. And we, you know, there's a separation between church and state. So we don't come telling you what you need to do in your church. We come providing you with facts and information and fact sheets and methods of how you can engage and meet people. And that's what we did. And I'm happy to say we were there half a day, and all of the fact sheets, everything that we took was gone. Everybody took it, we talked about how they could use it in the form of their ministries. And again, we don't go into a church and say you should do, no, here are the facts. You're here to protect your congregation. You want them to be healthy. You want them to have their diabetes under control. You want them to have their blood pressure under their control. You want them to know about prostate cancer and you want them to know about HIV. In order to do that, here's the information that we can share with you. I think it's a matter of doing that. Community engagement events help quite a bit to be able to do those types of things as well. And then our prevention communication branch does a lot of work with faith-based communities. And I can, direct you to someone who could help you with that as well. Anything?
And the only thing I'll add, and I used to actually, and Nicole knows, I used to work at 8 Atlanta many years ago. And what we would do is we were very strategic when we engaged faith-based organizations. Some would only want HIV testing. So we provided HIV testing, maybe on a Sunday or whenever they gave food out. So we would be there present. Some wanted key messages. So we gave them key messages to say, from the pulpit, these are the facts, these are the myths. If you are going to do a press release or you want to do something, check in with me so I can make sure your facts are correct. So I think every church is different. Right. So you have to have different strategic approaches to meeting each of them.
Right, and it also kind of sounds like, you have to be, those people in those places that you went to, those people are ready for the information, because if people aren't ready, then they're just not going to hear me. And I guess I'm trying to think ahead, like, what am I going to encounter and what information do I use to combat, people's...
I think sometimes you have to, because sometimes it's not the pastor. Yeah. It may be a deacon, it may be a member. You engage that person, and they can connect you with different ministries. Right. I think you just have to connect with the right person at the right church and make sure they look like us.
Right.
And I think too, if you start with, it's about our community in general, everything, the health of our community.
Right.
That's what I always say. It's about the health of our community. Okay. Whatever you believe, we're all here to do that. Right. And the church has taken a role in the health of our community throughout the ages. Right. So you're just there to make sure we're healthy.
Right. Okay.
This is a part of health, right?
It is.
Yeah.
All right.
Okay, thanks.
There we go.